Hello everybody and welcome to the fifth Ecg round. It's a very pleasure to introduce this fifth appointment on Cardio Education Online, in which we will speak about the clinical cases. Before to introduce our speaker, Professor Roberto Stantilly, I would like to remember you that you can use the Q&A session to post your questions. If you are following by Facebook group, you can post questions in the comments. We will keep and post to our speaker all your questions at the end of presentation. Now, I am glad to introduce you Professor Roberto Stantilly. Roberto Stantilly graduated from the College of Veterinary Medicine of the University of Milan in 1990. He became a diplomate of the European College of Veterinary Internal Medicine Companion Specialties of Cardiology in 1999. Between 2004 and 2006, he completed the Master in Electrophysiology and Electrical Stimulation at the University of Medicine of Insubria. He then obtained a PhD at the University of Turin, College of Veterinary Internal Medicine in 2010. Roberto Stantilly is the head of the cardiology department of the Clinica Veterinaria Malpensa Anicura in Samarate, Varese, and of the Ospedale Veterinario Portoni Rossi Anicura Bologna. Since 2014, he has been an adjunct professor of cardiology at the Cornell University College of Veterinary Medicine, where he is actively involved in the activities of cardiac electrophysiology laboratory. He is a co-author of the book Electrocardiography of the Dog and Cat, now translated in 9 languages. His main research activities include the diagnosis and treatment of arrhythmia in dogs and cats. Welcome again, and we can start with the presentation of Roberto Stantilly. Thank you.
Thank you very much. So here we are with our fifth ECG round. And today we will finish few ECG that we missed last time, and then we will discuss some clinical cases, including all instrumental findings and treatment options. So last time we had some few cases that we hadn't time to finish. So this is a female cat with bradyarrhythmias and pericardial effusion, and this is the ECG that has been sent. Here you can see this narrow QRS complex for a cat is less than 40 milliseconds, and we don't see a real atrial activation here, and we do see changes in the QRS complex amplitude on a variable on a beat-to-beat basis. If you look carefully, when you have long RR interval, it's a bit taller, here or here, and then when it's a short RR interval, it becomes less tall. So I think the underlying rhythm is an atrial fibrillation, and I agree that for a cat, it's probably below 160, so it's bradycardic. So I think it's an atrial fibrillation with a slow ventricular response. And I think we can diagnose the presence of a Brody effect. What's Brody effect is a change in the amplitude related to the feeling. So when you have a long RR interval, you have more left ventricular feeling, and this increases the amplitude. When you have a short RR interval, there is a decrease in the amplitude, and this is less ventricular feeling. So my final diagnosis is atrial fibrillation with slow ventricular response. It's quite rare in cats to have so slow response, but sometimes with cardiomyopathy this can happen. And the presence of this variation is mainly due to Brody effect. So why am I ruling out that this is due to the presence of pericardial fluid that obviously can induce this change? Because usually when you have pericardial fluid changing in the ECG amplitude, you also have a change in the ST segment, the T wave, and also in the area of the PQ. Also, here you don't have P because it's a fib, but still you have changes that is that are usually present in case of pericardial effusion. So I think Brody effect, and since it's related to the change in the RR interval, is the more probable diagnosis. Then we have another case from the same colleague. This is a male dog with paroxysmal tachycardia. Here is a normal looking ECG with a normal P. Then we have here a period of increased ventricular and atrial rate. And if you look carefully, we can see P waves that are just going into previous T, and these P waves are probably coming from the roof of the right atrium because they are positive in 2, 3, and AVF, and the more negative is AVR, and is also positive in lead 1. So the axis is directed toward plus 60, just like sinus P waves. But as you can see, the sinus P wave are taller, and these P wave are actually less tall. So it's probably what we call mid-crystal focal atrial tachycardia, because the axis of the P prime is crossing lead 2. So it's less tall. While when it's coming out from the sinus node, it's parallel to lead 2, so it's more 1 plus 60. Okay, so it's a focal atrial tachycardia arising from the mid-crystal, interrupted then by sinus beat, this one, and then this is a completely normal sinus rhythm, and interrupted by a ventricular ectopic beat. As you can see here, this is it's positive in lead 2, but then it's negative in lead V1. Obviously, we also need the rest of the precordial leads, but sometimes, I mean, the behavior that you have a post-extrasystolic pause can suggest to you the presence of a ventricular ectopic beat with retrograde VA conduction and reset of the sinus node. Then we have this very interesting ECG that has been posted by Dr. Fiedler in our Facebook group. This is a nice ECG where you can see, this is the tachogram, and this is part of the full disclosure, but you see you have period of sinus rhythm interrupted by prolonged sinus arrest and together with AV block. So this is a paroxysmal AV block. And then if you go here, you see there are always sinus arrest with AV block. So my first differential can be sick sinus syndrome, but why I do not think this is the cause, because if you go in the Poincaré plot or Lorentz plot in the histogram, you can actually see the presence of profound sinus arrhythmias, and with this escape that are very, very regular, starting from here to here. And the distribution of the RR interval is not the classical distribution for a sick sinus syndrome dog or a sinus node dysfunction dog. So it's important that when you have the normal Lorentz plot, you can actually rule out sinus node dysfunction. So what's the diagnosis? We have found some cases where the underlying disorder, it's an overreactivity of either mainly the AV node, but also the sinus node to the vagus. So it's an overreactivity to vagal stimulation, and this is called functional AV block. You can find functional AV block just like here with paroxysmal third-degree AV block together with an effect of the vagus on the sinus node, so you also have sinus arrest. So this is a very interesting differential diagnosis with sick sinus syndrome, but you can obviously have the differential looking at the tachogram here and the Poincaré plot here. So what's the treatment for this functional AV block? we had cases where the sinus arrest is very prolonged together with the AV block and without escape. So in this case, it's not symptomatic because you don't have escape, because you do have, a lot of escape, as you can see here in red. But in case you don't have enough escape and you have syncopal episode, I think you need to put a pacemaker, and it's usually well responding. So my answer for Dr. Fiedler, I don't know if I'm pronouncing well, but the diagnosis is functional AV block and sinus node dysfunction due to the presence of overreactivity to the vagal tone. So it's pathological, but here you have enough escape not to be considered a candidate for pacing. And Manuela, I'll keep going. If there is any question or anything, you can just interrupt me, okay? And
just a question about the ECG, the previous ECG.
This one?
No, yes. In your opinion, if in the first part there is a supraventricular tachycardia, there is a focal atrial tachycardia with a negative T wave, why during supraventricular tachycardia the T wave is different if compared to the sinus rhythm?
Okay, so I think it looks different, particularly here, because it becomes a little bit more deep if you compare this to this. And in some part, what you see is actually the P prime that it goes on top of previous T. But for sure, also when the P is not falling in the previous T, it's less deep. And I think this can be some repolarization abnormalities that you can have during rapid change in the heart rate. So sometimes you can have repolarization abnormalities, and you can have what we call QRS complex alternance, but are mainly repolarization abnormalities related to the faster rate.
Okay, thank you.
Okay, that's another case, and then we move to clinical case. This is another case very interesting that has been posted on our Facebook group from Dr. Castaner. And this is a dog that is an old dog, actually 12 years old, refer for panting. He has a slightly elevated troponin and a normal X-rays and so on. So what you see here, it's two different QRS complex morphology and two different PQ interval. And so what is interesting that you have a slight change of the of the ventricular rate, and then it's stabilized with this type of QRS complex appearance. So my diagnosis for this is that when it has this type of appearance, this is pre-excited, because you see there is a delta here and a double peak QRS complex. In AVR, it's completely positive. Then when he has a change, the PQ gets a little bit longer and a Q appear, that's the septal vector, and a narrow QRS complex. And then back to this. So it's the differential diagnosis is he has intermittent pre-excitation, or he has what we call the Concertina effect. And intermittent pre-excitation is defined as the presence and absence of pre-excitation, and is a usually change, so loss of delta, prolongation of the PQ interval, and normalization of the QRS complex as TNT that is not related to changes in the heart rate. While Concertina effect, it's another type of intermittent where there is a progressive change of the PQ, QRS complex, appearance of delta, and appearance of changes in the STT. So if we go back here, you see that you have a progressive change from this to this, and then this. So it's from non-pre-excited to pre-excited. So it's more gradual. And this is called Concertina Effect. So it's more like the second option. And that's why we consider this the possible diagnosis. So for Concertina Effect, this is another example that you can see in human, where you have this type of pre-excitation, then goes back to an almost normal, and then pre-excited back. This is interesting because in human, when you have pre-excitation, it's in high risk of sudden death, because you can have antegrade conduction along the accessory pathways, particularly of atrial fibrillation. Concertina effect is a good sign, because it means that the antegrade effective refractory period of the accessory pathway is very long. And since it's long, it's very rare that an antegrade atrial fibrillation can be conducted to the ventricle, inducing ventricular fibrillation. So it's when you see Concertina effect, it's a good clinical sign for, prognostic point of view. All right, let's move now to our first clinical case. This is a dog with that has been referred to our hospital. It's a medium-sized dog with mitral valve disease, congestive heart failure, and tachyarrhythmias. He came with a very high dose of furosemide, benazepril, and pimobendan, and despite this high dose, he was in failure. So we classify this dog as a class D patient. According to the guideline, usually when you stay more than 8 mg per kg and you go up to 12 mg per kg of furosemide daily, is usually considered class D. It's very arbitral, but usually when you consider that you have what we call furosemide resistance. Remember that this dog is in class C, but is not using spironolactone, and usually in class C, the guideline is suggesting the use of spironolactone. And there are also new studies about the use of spironolactone in dog in this stage. But so if you look at the ECG, we can see narrow QRS complex, irregular interval, and absence of the P waves. And we have some little F waves. So what you have to do to be 100% sure that this is a AFib. Yes, it's an AFib because you don't have coordinated atrial activation. That's first. Second, I want to see all different parts of the atria that are fibrillated in the same way. So first of all, I look the interatrial septum. So this is lead 2. And you see that the interatrial septum, remember, this is an important muscular part of the atria, is fibrillating with very, very tiny F wave. Because why are we doing this? Because we want to classify the atrial fibrillation if it's paroxysmal, long-standing, persistent long-standing, and persistent long-standing, or permanent. So usually when you have all the atria with tiny F waves, just like this one, these are considered long-standing. And so long-standing for a human is 1 year. For dog, we don't know yet, but probably around 4 to 5 to maximum 6 months of fibrillation. So the interatrial septum is fibrillating. Then I want to look at the left atrium, and I look in AVL. AVL is also fibrillating with very, very flat F wave. And then using our precordial system, I also want to look at the right atrium, and also the right atrium is a fine fibrillation, coarse fibrillation. So for sure, this dog has a long-standing, persistent atrial fibrillation. All the atrial walls are fibrillating has been fibrillating for long times, and therefore, usually, if you don't consider to cardiovert, and I don't consider it because it's an old dog with severe mitral valve disease and class D cardiac failure, I really consider this permanent atrial fibrillation. So I don't want to do anything to cardiovert and restore sinus rhythm. And this is the echo. As you can see, is a severe left atrial enlargement, myxomatous mitral valve proliferation, volume overload with hyperkinetic heart. And then if you move to your right-hand side, you can see a very, very tall E wave, almost 2, meaning that you have a very severe increase in the preload and left atrial pressure, regardless the presence of a very, very high dose of furosemide. So what do you want to do in a case like this? We want to control congestive heart failure. Since he's a probably class D patient, we wanted to do something. Remember that 1/3 of the dog in class C, advanced class C, has what we call aldosterone breakthrough, meaning that we have alternative pathways despite the use of benazepril. So despite the use of an ACE inhibitor, is in this particular case, there is probably an activation of aldosterone from different pathways. So the first mistake for this dog was not to use spironolactone already in this phase of the cardiac failure. And second, it's important that you can also have, for the chronic use of furosemide, you can have what we call a braking effect. So when there is a change in the epithelium of the loop of Henle, and therefore the furosemide is not working enough. So if you have aldosterone breakthrough together with a diuretic resistance, this is time to change the different type of drugs and to add spironolactone. So what we did, we wanted to use torsemide. As you know, torsemide is very, very powerful diuretic. It can be used once a day in a class C patient, but usually in class D, it can be used, you can start using it once a day and then move to twice a day with higher dose. Remember that in class C, usually we use very low dose. Once a day, we use 0.12, 0.13 in an average mg per kg once a day. But then when it goes into class C, we really need to use most of the time twice a day. What we also do when the congestion is not controlled, just like in this case, we also add furosemide subcute if ezetimibe alone is not enough. Then we really want to add spironolactone, so you can use this combination, and we want to use spironolactone because we suspect a braking effect. How you can diagnose braking effect in this patient before using spironolactone? You can do the aldosterone creatinine ratio in the urine, and if it's more than 1, that means that you have an alternative activation of the ACE, and therefore you have a production of aldosterone through the kinase. And if you use spironolactone, you can stop this and you can improve the effectiveness of the loop diuretic. Remember that torsemide is very potent. It's less common with torsemide to have the diuretic resistance. Is less common, very, very much less common than compared to furosemide. And the other important thing that has been shown that torsemide can also have some anti-aldosterone effect. So it is a potent drug that now we have been using for a while and we think is very effective. And then we obviously changed the dose of pimobendan in increasing the dose up to 3 times per day. And that's all the thing that you can do to treat the severe refractory congestion in class D patient. Then, as you can see, AFib was a very fast response, but we didn't treat acutely AFib, because we want to first control the ventricular rate treating the congestion. So we have a decrease in the sympathetic drive, and this will induce a drop in the rate, but not in all cases, but in most cases. So in this particular case, we wanted to check after 7 days of treatment, we had a complete resolution of congestion, and we did a Holter. So with the Holter, this is the tachogram. Remember, when you have atrial fibrillation and you look at the tachogram, you are not looking on the sinus node function, but on the AV node function. And in this particular case, if you draw a line here around 400, most of the day and night, this dog has a heart rate above 160, 140. So this is not good. So it means that we didn't reach a complete control despite the congestive heart failure control. And remember not to look just on the average heart rate, but look also on the amount of times that you have a rate below the 140 beat per minute, because otherwise just the average is not enough. So what we did, we start with digoxin. We are doing, and some of you are participating to our study, the AFIRC study. We are want to try to see in which cases you can have a control of the heart rate just using digoxin alone, and with a DIG level 10 hours post pills of at least 0.8 up to 1.2 nanogram per deciliter. And in this particular case, the congestion was so bad that, as you can see, you can start seeing some changes in the longer RR interval up here, but not enough. Maybe something during night here. You see some long RR interval here. Remember, the best vagal control is between 4 and 6 in dogs. And at that time, all dogs should be bradycardic if possible. And in this particular case, we have some changes in slowing the heart rate in this part, but during the day is not a lot. And as you see, the average heart rate drop a little bit, but not enough. So this is one case where digoxin alone does not work, but we are now seeing a lot of cases. We usually read with our telemedicine service up to 120 Holters per month, and we saw a lot of atrial fibrillation cases, and I have to say that a lot of cases with just digoxin we can control the average heart rate over time. But in this particular case, we could not, and so we add diltiazem on top of it. And now, as you can see, look how nicely now we have, for all night and all days, a lot of period with very, very long RR interval, very, very long. And this is the average R rate drop. But what we want to see again is also this different distribution of the RR interval. So now we got a congestive heart failure control and heart rate control of this permanent atrial fibrillation. So, but 2 months after, suddenly he came back with acute weakness, pale mucous membrane, cold extremities, bradyarrhythmia, and a normal DIG level. So the first things that we suspected obviously is a digoxin intoxication, because maybe he developed renal failure, or he developed hypokalemia, or he developed low albumin level. These are the 3 main causes to have digoxin increased levels and therefore digoxin toxicity. Remember that to have the effect on the AV node, we want very low level of digoxin to have, the effect on the AV node through the activation of the receptor of the vagus. But at very high dose, you have increased calcium within the cells, and you have increased toxicity and on the myocardium and on the general body. So we suspect an acute cardiac shock, and we wanted to understand what's going on, and that was the ECG. So suddenly this dog has prolonged sinus arrest, and if you look carefully, you have some form of atrial activation here, and sometimes the precordial lead can help you in this understanding. And as you can see also here, and then you have ventricular escape here. And then if you look, he had again a P wave. You see that the right atrium is working properly with a nice P wave, and then in the other leads is almost flat because the left atrium is working not really properly for the long-standing persistent AFib. So now we have to go back. It was not a permanent AFib, it was just a long-standing that for some reason this dog went back to sinus without, any provision. And why did this happen? We really don't know 100% because neither digoxin nor diltiazem can induce a cardioversion. And a pharmacological cardioversion can be obtained just with a class 3 agent in dogs, so amiodarone, in some particular case, and in human with a class 1C, so mainly propafenone. So this is the main drug to cardiovert pharmacologically. So why this dog went back? Look how bad was the bradycardia for this particular patient. So I remember that when you have severe mitral valve and a lot of your blood is going back to the left atrium, you have a drop in the stroke volume. I think a dog like this has almost 75% of backwards flow and just 25% of antegrade flow. And therefore, if you drop the heart rate, since you have already a drop of stroke volume, you have a fall of the cardiac output. And that's why this dog was in cardiogenic shock. It's a bradycardic cardiogenic shock. So we recheck after 24 hours, and digoxin was stopped and diltiazem too, and after 24 hours, the dog was back in atrial fibrillation. And at that point, the ventricular rate went back to normal. And we asked to the owner, because our idea was an overdose of diltiazem for sure, because the DIG level were normal. But the owner, wasn't happy with our diagnosis. He swear that it was not possible, but we couldn't find other option, because if you think there are several reflexes in the heart, but are usually not very long standing. For example, the basal-Yarish reflex is very common in dogs with congestive heart failure and atrial fibrillation, and these induce, there is a stimulation of the C fibers within the myocard, the left ventricle mainly, when the heart is beating and it's empty, particularly during AFib. This induces a profound inappropriate vagal reflex with AV block. So the AFib stops with prolonged ventricular arrest together with vasodilation. But these last few seconds, in some case minutes, but not 8 hours, just like in this case. And the same for other form of vagal reflex. So we suspect a diltiazem overdose. Then why the profound bradycardia cardiovert this dog is not clear 100%, but the very likely diagnosis is diltiazem overdose. Is there any question about this case?
Some questions about this case and some other questions.
I cannot hear you.
So we have some questions about this case and some other questions about the previous ECGs. So starting from case 1, so this case about atrial fibrillation, Dr. Artaras is asking, what about adding amlodipine to other drugs in this case?
Okay, yeah, that's another option. We do add amlodipine on top of all these drugs when we cannot reduce the amount of pulmonary edema. Because when you have class C dog, you know, some of them has combined pre-capillary and post-capillary pulmonary hypertension, and they have right heart failure. At that point, we add, you know, furosemide subcute on top of Izemid. But if you have mainly left heart failure with refractory pulmonary edema and recurrent pulmonary edema, it's a very, very good option to add amlodipine, because it's been shown that amlodipine can reduce left atrial pressure and therefore left ventricular preload. So I do agree, but mainly in refractory, in recurrent pulmonary edema, and less frequently in dogs with combined pulmonary hypertension and ascites.
Okay, and about case 1 again, Dr. Ang is asking, with this high dose of diuretics, do you worry about renal function and hypokalemia?
Okay,
When the diuretics are used together with digoxin?
okay, that's a good point. So usually we were much more worried about the use of high dose of furosemide in dogs with congestive heart failure. But you know, with the several years of experience, we have to say there are some dogs that can develop kidney problem, and you know, the different types of cardiorenal syndrome. But I think that this is not true in most of the dog. Remember that when you have dog in class D, the amount of sodium retention and the amount of volume overload and the amount of increase of plasma volume is so important that you really need high dose of Izemid or furosemide together, or Izemid alone, to control it. So we have no choice. So then the problem is that obviously in the future maybe we will do more mitral valve repair or mitral valve clips or whatever we will do in the future, and we probably won't have any more so severe case, particularly if the price of this procedure will drop. But at this point we have no choice, and I have to say that in my experience most dogs can handle high dose of Izemid and furosemide, or Izemid alone, or Izemid plus furosemide. But in class D, I think that shift to Izemid torsemide, it's the goal, because we want to decrease the diuretic resistance. We want to decrease the braking effect on the loop of Henle, and we want to add further anti-aldosterone effect. So it can happen. I don't think it's as common as we believe.
Okay, again about case 1. Was diltiazem stopped forever, or was diltiazem restarted after atrial fibrillation reappeared?
We checked later on. Obviously, this dog has an advanced heart failure, and I think a few months later he died. But we start back both drugs, and with a lot of advice to the owner to be sure not to over dose again the diltiazem, despite it wasn't, I mean, convincing that he did not, but we start back and we could control the AFib long term.
Okay, just was one question about the Concertina Effect from Dr. Ernesto Artaraz. Do you consider medical treatment for the Concertina Effect or in general from pre-excitation syndrome?
All right, so this is a good question. For the Concertina Effect by itself, no, because it's a good ECG finding suggesting that the antegrade accessory pathway a refractory period is long, so there is no risk of sudden death due to paroxysmal AFib that becomes pre-excited. But in a case like this, obviously it's a 12-year-old dog. It's very rare, but it can happen. In our case, in our studies that we published in 2018 about, I don't remember, but I think more than 85 accessory pathways, just one of them has only antegrade conduction, but the remaining, so 99% of the accessory pathway has also retrograde conduction, so reciprocating tachycardia. So it's very important to remember that when you have pre-excitation, you really need to be sure that you also have reciprocating tachycardia, and that's the one that I need to treat. So it's the reciprocating tachycardia, not the pre-excitation by itself.
Okay, now we need to review the overreactivity of the vagus nerve on the sinus node because we have two questions about that case. So the first question by Sandra Grekenbauer is, do you think that the exercise intolerance is not caused by the functional AV block?
It can be. For sure, the functional AV block is also inducing prolonged sinus arrest, mainly when the vagus is activated. That means that usually the dogs that we found and in which we implanted pacemakers are mainly syncopal episode during rest or even sleep. So it's not. I mean, the sinus node and the AV node are structurally normal. The problem is an overreactivity, so they respond too much to the vagus. So what happened during exercise in most of the cases that we had, that usually they can respond to the high sympathetic drive. So it's mainly a vagal overreactivity, so during the high vagal tone. So that's the difference. While when you have sinus node dysfunction, the real sinus node dysfunction, you also have unresponsiveness to the sympathetic drive, and so you have chronotropic incompetence, meaning that you don't have enough heart rate, so the heart rate is not fast enough for your metabolic demand, particularly during exercise.
Okay, and about this case, Dr. Fiedler is asking if in his case you suggest to use vagolytics and repeat Holter, or just to repeat Holter within 3-6 months.
All right, if the dog is not symptomatic, obviously we don't know for this dog what happened when he has prolonged pauses. Because if you look in your Holter, when he has the escape rhythm during paroxysmal functional AV block, it's quite slow, but not slow enough to induce, loss of consciousness. So if you don't have clinical sign, it's probably not needed to do anything. But it's very likely that this dog in the future can develop clinical signs. And usually at that time, I think the best way to go is to implant a pacemaker.
Okay, thank you very much.
All right. So I think we have time for the last case. And this is a Dog de Bordeaux male, 5 years old. He was first diagnosed a long-standing persistent atrial fibrillation. They call it lone AFib, meaning that it was present without any underlying heart disease. But then, looking at the Holter, the referring vet put this dog on digoxin. And digoxin is, you know, a nodal blocker. And as a nodal blocker, it can usually decrease ventricular response according to the dose. And usually, again, I already told that, but we need very low dose. You have to stay below 1.2 ditch level after 10 hours post-pill. So what happened, because this dog came back with acute weakness and polypnea. And this was the ECG. As you can see in the first part of the ECG, we have a narrow rhythm with narrow QRS complex. We have fibrillating. Again, it's a fine fibrillation in lead 2, interatrial septum, AVL, left ventricle, and left atrium, and V1, right atrium. So it's a long-standing AFib. We agree. The rate is a bit fast, but then what happens suddenly? We have a wide QRS complex tachycardia. And if we look at the RR interval, is mainly regular, okay? So our first differential when we have a wide QRS complex rhythm is really ventricular tachycardia. But since we have a fast tachycardia and a fast atrial fibrillation, and I forgot to say that this left ventricle wasn't healthy. You see that we have a widening of the QRS complex and a slurring. So there is a slowing of the downstroke of the QRS complex. And then remember, we talk about the R-peak time. So is the time of velocity of conduction from the endocardium to the epicardium. In lead V1, this is the right ventricles. You see there is from the beginning of the QRS complex to the reach of the R is very fast. While if you compare from the beginning of the QRS complex to the peak of the left ventricle from lead V2 to lead V6, it's very, very delayed. Usually the distance between the peak in V1 of the R and the peak in V2, starting from the beginning, should be less than 15 milliseconds. So less than 1 millimeter at 50 millimeter per second of paper speed. So this is interventricular dysynchrony. So this dog has already an interventricular dysynchrony and conduction delay within the left ventricle. So that's why as soon as I saw that, my differential in my mind were, is this an atrial fibrillation conducted with aberrancy because the rate got faster, or it's a ventricular tachycardia? And so 90% of the cases is usually VTAC, but we have 10% of the cases where it's an atrial fibrillation conducted with aberrancy, and since it's sustained, this is called phase 3 linking. So it's a linking induced by tachycardia. So what I have to do, I don't have P waves. So the first things to do is usually to rule in ventricular tachycardia is to look for the presence of sinus P wave dissociated from the QRS complex. And this is not the case because we have a AFib, so we cannot see that. So my second step is to look at the morphology of the QRS complex. And is this a left bundle branch block? So in case of left bundle branch block, we have a normal axis in the frontal plane. So 2, 3, and AVF should be positive. Usually lead 1 is also positive, and this is the case. So it looks like a left bundle branch block. Then I want to see on the horizontal plane is the same. So from lead V2 to V6 that are reading the left ventricle, they are all positive. This is left bundle branch block. Exactly just like 2, 3, and AVF. And then we have V1 that is negative, exactly just like AVR. All right, so this is looks like a complete left bundle branch block. So now I have to do my differential. So is this a ventricular tachycardia, or is this an atrial fibrillation conducted with phase 3 linking? So I cannot say 100% which one is. The only thing that make me worry about VTAC is the irregularity of the RR interval. But be careful, because sometimes when the ventricular rate is very, very fast, AFib can look regular. But then if you measure the RR interval, it has to change a few milliseconds. In this particular case, was very, very regular. So usually ventricular tachycardia do not respond to the rule of the bundle branch block. So it's very unlikely that you have a bundle branch block appearance with this type of activation pattern. So that looks exactly like a left bundle branch block. The only exception is when the ventricular arrhythmia arises from the right ventricular outflow tract. For example, in English bulldog with the RVC, and it's very common also in dog de Bordeaux. We don't know if they have RVC, we couldn't prove yet, but there are a lot of dog de Bordeaux that has congestive heart failure, atrial fibrillation, and ventricular arrhythmia arising from the right ventricular outflow tract. So what we did in this case, we check over time and we see what happened. You got this that was regular and we suspect as VT, and we were convinced that it was a VT because suddenly you see you have a fusion. So you have a fusion of the beat that is coming from the atria, so from and going along the AV node with the beat coming from the ventricle, and so you got a fusion beat that is a sign of VA dissociation, so ventricular atrial dissociation. Since he has ventricular arrhythmia, severe systolic dysfunction of the ventricle, it was already on digoxin, we add amiodarone. And amiodarone controlled the ventricular tachycardia while digoxin controlled the ventricular response of atrial fibrillation. Remember, it's very, very important. In our experience, we could, and we read 100,000 of Holters, we never found a case in which amiodarone controlled the ventricular rate, despite he has, other than class 3, also class 2 effect, so beta blocking effect. We couldn't find any case of a decreased response. We did find cases of cardioversion and restoring of sinus rhythm, but we could not find any case of control of the ventricular response. So this was a nice case in which we could do the diagnosis because we did a long 5 minutes ECG and we couldn't find a fusion beat that was our diagnostic sign for a ventricular rhythm arising from the right ventricular outflow tract. And then we treated with amio. We usually use 50 mg per kg twice a day for 48 hours. And then we drop to 7.5 BID. And again, this is now just a fib. It's lower because he has also digoxin on board. Remember always to look. Now we have a paper that will come out in the next months on JDC about the use of the IDE. So is the dysynchrony, interventricular dysynchrony index, and we will explain to you. I think we will do a journal club on that, maybe either on Facebook or on Instagram, to show you the importance of looking at the R peak time in lead V1 and in lead from V2 to V5, V6, particularly V5. And again, look how nicely the distance between the beginning to the peak of R in the right ventricle is earlier than the peak in V2, much more than 15 milliseconds. So this dog, we know he has severe interventricular dysynchrony due to a fibrotic or fibrofatty. We don't know because we couldn't do any biopsy in this dog, but there is the conduction along the left ventricle is delayed. And so you have a drop in cardiac output and increase in drop in stroke volume and an increase in sympathetic drive. All right, I think we are done. Is there any questions for this case? And I think it's already 8 o'clock.
No, there is no question about the last case.
All right. So I think we have done. We will have our next ECG round it's going to be in December. And so in this round, if you like, we will try to do again some clinical cases and some of your ECG that you will post in our Facebook group, or that you will just send us by email. All right. Thank you very much for participating.
Thank you.
Thank you. And we will meet again in our ECG round in December. We will post in Facebook exactly the date of the new ECG round. Bye-bye to everybody.
Bye.